take this opportunity to introduce Dr. Ankit Singh Tomar. He did his MD from AIMS in New Delhi. He went on to do his oculoplasty and ocular oncology fellowship under Dr. Santosh Hunawar, who was the HOD of oculoplasty and ocular oncology at Center for Sight in Hyderabad. Dr. Ankit further went to do ocular oncology and orbital radiation fellowship under Dr. Paul Finger at the New York Eye Cancer Center and the New York Eye and Ear Infirmary in Mount Sinai Hospital in New York in USA. He has completed his FRCS and FICO, and he has several accepted manuscripts in prestigious journals around the world. Dr. Ankit has written several chapters in different books, and he has won several awards. To name a few, he has received the Best of the Show Award in American Academy of Ophthalmology in 2018 for his paper titled OSN Not One Size Fits All. He has also received the Sujata Savitri Rao Award, Best Free Paper in Orbit in Oculoplasty at the 77th AIUS Conference. And then he has won 2 Best Video Presentation Awards, again at the 77th AIUS. He has also received the Dr. R.C. Gupta Best Poster Award from the Oculoplasty Association of India Annual Meet in 2018. He has received the Best Video Film Award, again from Oculoplasty Association. He is winner of the travel grant for the Asia Pacific Society from Ophthalmic Plastic and Reconstructive Surgery in 2018 in Hong Kong. And he also won the travel grant for International Society of Ocular Oncology. We are very fortunate to have Dr. Ankit Tomar, who has just returned from the US and will now be settling down in India to further his expertise. Very warm welcome to you, Dr. Ankit Singh Tomar. We'd like you to speak on choroidal tumors, please.
Good evening, everyone. My name is Dr. Ankit Singh Tomar, and today we'll be talking about the basics of choroidal tumor. Thank you, Dr. Sinha and Dr. Khetan, for this opportunity, and thank you for your kind words. Before I start, I would like to thank my mentors, Dr. Santosh Hunawar and Dr. Paul Finger, who have taught me everything that I know in ocular oncology. They've always told me to teach is to learn twice, so make sure the chain reaction never stops. I was a resident like you all 5 years back, not too long ago. So I'll try to cover all these topics with a focus on postgraduate exams. Please don't hesitate to ask any questions in between. Let's begin with the most common benign lesion of choroid, the choroidal nevis. It arises from choroidal melanocytes. It's often flat with ill-defined margins. It can be slate gray or pigmented. Some can be amelanotic. Common signs of chronicity include presence of overlying drusen on its surface and a hypopigmented halo around its margin. As you can see, the size can extend from a small nevis to a really large nevis, and some can also lack pigment. Let's describe these pictures one by one. The clinical picture shows a pigmented lesion, which is on the nasal side of the disc, about 2 disc diameter in size, 2 to 3 disc diameter from the optic nerve. It has irregular margins, some yellowish white deposits on its surface that are the drusens. If you look at the OCT scan through the lesion, we can see this irregular line, which is hyperreflective, which is suggestive of drusenoid RPEDs. The next picture, which is on the right side upper corner, this one is an autofluorescence image. How do I know that? It's because the blood vessels appear black. We can see those bright white spots in between, which are hyperautofluorescent. These are suggestive of lipofuscin or orange pigment seen clinically. It is suggestive of abnormal metabolic activity on the surface of nevis. We'll see more pictures of these later. The right bottom one is fluorescein angiography in late phase. It is grossly unremarkable, but some hyperfluorescent spots which suggest microaneurysms, which can occasionally be seen with nevi. Now, what do I do with this lesion? It is essentially benign, and hence a baseline documentation with clinical photos and ultrasound is needed. They do grow, albeit very slowly, in about 30% cases. Do I need to worry about a growing nevis? Yes, because there's a risk of transformation to malignant melanoma. Annual risk of malignant transformation is between 1 in 5,000 to 1 in 10,000 by different studies. and about 2 to 13% of these lesions do transform into their malignant counterparts. To identify the specific subset of nevi which are at a risk of malignant transformation, I follow my mentor, Dr. Finger's mnemonic, MOST, where M stands for melanoma, O for orange pigments, S for subretinal fluid, and T for thickness more than 2 millimeters. Presence of these three features are highly suggestive of malignant transformation of nevis. Some other suspicious features include proximity to optic nerve, presence of symptoms in form of flashes, floaters, or loss of vision, and absence of drusen or hyperpigmented halo. We'll tackle them all one by one. Let's discuss, like we discussed previously, orange pigments are suggestive of abnormal metabolic activity over the nevis surface. As you can, I don't know how clearly you can see these orange pigments, which are highlighted by this arrow here. But once we see the autofluorescence imaging, they are very clearly illuminated. There are very few lesions which are hyperautofluorescent, orange pigments, drusen, and optic disc hamartoma. So autofluorescence becomes an invaluable tool while examining a pigmented choroidal lesion and should be employed to follow up a lesion to monitor any change. Even a change in the pattern of autofluorescence over time is suspicious because it signifies some continuous activity. And we have to make sure that we have a discussion with the patient regarding this and follow them up closely. Next comes fluid. Any fluid, whether obvious subretinal fluid, like the image on the right, or subtle subretinal fluid, like the small intraretinal pockets of fluids on the image on the left. These are suggestive of abnormal leaky capillaries. OCT raster scan over the nevis surface with special attention to the inferior aspect of the lesion helps us catch even the smallest amount of these fluid pockets. The third aspect is the thickness of the tumor. If the thickness is more than 2 millimeters, then we have our suspicion. Ultrasound B scan is a great tool to measure thickness. As we can see that this is a really flat lesion, but we still could measure the thickness accurately. Sometimes for small lesions, OCT can also help us delineate the thickness. You can see in the OCT scan, there is a small pocket of fluid and some abnormal irregularities on the inner retinal layer. These are dysmorphic photoreceptors because of chronicity of these disease. If all these three features, that is orange pigments, subretinal fluid, and tumor thickness more than 2 millimeters are present, there's a very high chance of malignant melanoma. And we can discuss the implications and management plans with the patients. But what if only 1 or 2 of these signs are present? Then the best course of action would be to follow up the patient in 8 to 12 weeks of time and to look for any change. If no change, we can increase the follow-up. But if there's a change, then we can discuss with the patient treatment options. Now let's talk about the big bad lesion, uveal melanoma. Iris and ciliary body melanoma form a small proportion of the cases, whereas majority are choroidal melanomas. We'll discuss the other two briefly later. Choroidal melanoma is a disease of middle age and elderly. Having said that, we do see some young patients who get this rare tumor. The younger population tends to have a better prognosis due to better systemic immunity. Racially, it is a disease seen more commonly in Caucasians, the typical description being blonde-eyed, fair-skinned. There is a higher risk in patients with nevus of OTA, which is oculodermal melanocytosis, and neurofibromatosis 1. From yesterday's discussion, we know that NF1 is a notorious systemic disease and can have other features like optic nerve glioma also associated with it. Now, uveal melanoma is primarily diagnosed clinically. So a careful indirect ophthalmoscopy is a must. These lesions can be large or pigmented and sometimes can also be amelanotic. In the image on the right side, this is the lesion, whereas the inferior lesion is just a pigmented scar which is unrelated to the tumor. Ultrasound helps us get the accurate tumor height and basal dimension and helps in treatment plan. It can, these tumors can acquire the classical mushroom shape, which we can see on the left side, and the collar stud appearance also. It can also have a associated exudative retinal detachment. Since it's a serous retinal detachment, it can have shifting fluid appearance. Now, if you want to describe this ultrasound, it shows a dome-shaped choroidal lesion with low to moderate internal reflectivity If I had the A scanner joining with, the slow to moderate internal reflectivity would be very clear. There is an adjacent exudative detachment on the inferior side. I hope you guys can see that. And there is no extrascleral extension. So whenever we are describing the ultrasound of a melanoma, we have to incorporate all these features: tumor shape, tumor size, internal reflectivity, any associated detachment, any extrascleral extension. If we talk about the fluorescein angiography, sometimes we can see the classic double circulation pattern with the dye lighting up the overlying larger retinal vessels as well as the internal network of the tumor vessels. FFA is not a must for diagnosis, but it can aid, especially in suspicious cases where we need to differentiate it from other lesions, for instance, maybe a hemangioma. Now, how do we approach the treatment? The most important thing is to have a detailed discussion with the patient regarding the pros and cons of all treatment options so that they can make an informed choice. A suspicious lesion can be observed for documented growth or change before we treat it. The main treatment options for a clear melanoma are either radiation or enucleation, which we'll discuss subsequently. The other treatment options like TTT and PDT, they're not used as primary therapies. They're usually used as adjunctive or add-on treatment. At some time they were in vogue, but we found that they have a higher recurrence rate, hence we abolished using them as primary treatment modalities. Surgical excision can be employed for smaller, medium-sized lesions, but it is fraught with the risk of bleeding, retinal detachment, sympathetic ophthalmia, phthisis. Also, we need prolonged hypertensive anesthesia, so it is seldom performed. Exenteration is limited in cases with extrascleral extension and orbital involvement. In the early 20th century, there was this controversy regarding enucleation. It was postulated by Dr. Zimmerman that increased intraocular pressure during enucleation results in metastasis. He saw that the mortality peaked 2 to 3 years after enucleation, and it was attributed to the procedure. So, a large multi-center study was conducted by the name of Collaborative Ocular Melanoma Study. It is an excellent example across medicine as to how to study rare disorders. They enrolled around 2,500 patients in the 1980s in America and Canada across 43 centers. 3 tumor classes were defined based on tumor height and basal dimensions. These values specifically about the tumor height are important for postgraduate levels. The small melanomas, they were observed. Medium-sized tumors were randomized between enucleation and plaque brachytherapy, whereas the large tumors had enucleation with or without radiation. Let's discuss each one by one. So the small melanoma group, about 204 patients were there, and they found that only 1/3 grew over 5 years, whereas 2/3 did not. The risk factor for growth were noted as orange pigments, more than 2 mm tumor thickness, and more than 12 mm basal dimension. Another important finding was that melanoma-specific death was only 1% over 5 years. In medium melanoma size group, they had about 1,300 patients, and they found that either of the treatment did not offer survival advantage over the other. In other words, whether you enucleate or irradiate, the patient had same chances of getting metastasis. The third group, that is the large size group, also found no survival difference between the two arms. This is in stark contrast to Zimmerman hypothesis, which said that metastasis occurred at the time of enucleation. So to conclude, the results of COMS were that small melanomas, only 1/3 of them grew over a period of 5 years of time, and they had a small risk of metastasis of 1%. Radiation is equivalent to enucleation in terms of metastatic risk, and enucleation does not worsen the risk of metastasis. But there has been some time since this study. Where does the current medical evidence take us? We believe that treatment modality has no role in the prognosis of the patient, and it is the genetic profile of the tumor which decides the risk of metastasis. We'll talk about the genetic profile later. So currently, our main aim is to provide local treatment to the tumor. But there's one more unanswered question. When does the tumor actually start metastasizing? For instance, if a patient has a small tumor and wants to delay treatment, is that okay? So there was this study which found that metastasis was detected on an average of 2.2 years after primary diagnosis, quite similar to Zimmerman's observation. And these metastatic deposits, they developed from micrometastasis, which happened when the tumor was smaller. How small, you ask? About 7 cubic millimeters, quite tiny actually. which is about 3 millimeters basal dimension and 1.5 millimeters height. So we can conclude that if we know that the lesion is malignant melanoma, we should not delay the treatment irrespective of the size because of the risk of micrometastasis. Let's talk about treatment options. So first is enucleation. It is infrequently used now because earlier detection and better treatment modalities are available. But we have to acknowledge that it is a life-saving modality and can be used in conditions like large tumors, especially which are AJCC T4. As you can see, for T4 criteria, the basal dimension can be more than 18 millimeters and the tumor height can be more than 12 to 15 millimeters, which is quite huge. In cases where there is optic disc invasion, because chances of vision gain are very low and it's very difficult to treat optic disc involvement with radiation. When there is extensive involvement of ciliary body or angle, like ring melanoma, where 360 degree of the angle and ciliary body are involved. Irreversible loss of useful vision or blind painful eye. And when the patient has poor motivation to keep the eye. With advances in ocular prosthesis, the cosmetic outcomes of enucleation are excellent. So we need to counsel the patient accordingly for this aspect too. Now let's come to radiation. It can be delivered in form of plaque brachytherapy, where a small radioactive disc is sutured onto the sclera underneath the tumor for a predetermined duration, and radiation is delivered to it. The patient needs to be followed up indefinitely because there is a risk of radiation retinopathy, which can be treated easily with anti-VEGF injections, but follow-up is a must whenever a patient is being treated with radiation. For plaque brachytherapy, we have different radioactive isotopes, including ruthenium 106, palladium 103, iodine 125. But the basic principle remains that the tumor margin plus 2 to 3 millimeters of an extra margin should be covered by the plaque to avoid any geographic miss. Because if the tumor is not irradiated, there will be a recurrence. And recurrent tumors have a very high risk of metastasis, almost 6.3 times as per studies. If you look at the pictures, the picture on the top side shows a golden plaque, which is usually for customized plaques that are iodine and palladium. And the ones on the bottom are silver plaques, which are for ruthenium. The one on the right is the notch plaque, which is specifically used for peripapillary tumors around the optic nerve. This notch fits around the optic nerve. Now, if you were to compare iodine and ruthenium, iodine is more commonly used in the United States. It gives off gamma radiations, which have a higher penetration. It is assembled, so that means it is customized for every single patient. There is a gold plaque, and the iodine seeds are stuck to it. And because of all this process, it's relatively expensive. In contrast, ruthenium 106, it's more commonly used in Europe and Asia. It gives off beta radiation, which limits its utility to tumors less than 7 millimeters in height, because beyond this height, the radiation does not reach tumoricidal concentration. It is relatively inexpensive and can be reused. As you can also see, its half-life is also nearly a year, so it can be, it remains hot for a long time, in contrast to iodine. Other form of delivering radiation is proton beam therapy. It has advantage over conventional radiation that it uses protons instead of photons, which provides better accuracy and its ability to spare healthy tissue. When photons, that is like our X-ray or CT scan or EBRT, when photon is delivered to a tumor, it deposits considerable energy to tissues along the path, which results in more side effects. Protons, because of its physical property, that is Bragg's peak, it allows it to deposit less energy on the way to the tumor and does not affect any tissue beyond the target. Hence, in total, there is lesser radiation-related side effects. To deliver proton beam radiation therapy, we need to suture tantalum clips as guide, and then the patient is sent off for proton radiation. Another point to note is proton and plaque brachytherapy have equivalent success rate and comparable prognosis. Let's talk about the genetic markers and gene expression profile. We briefly discussed previously that the genetic makeup of the tumor tells the tumor if it knows how to spread or not. Here, GEP stands for gene expression profile. Let me first talk about how that is done actually. So tumor tissue is needed for that. We can either take it through a biopsy or through an enucleation specimen. They're tested for the RNA levels, for their corresponding 15 genes. Higher RNA levels suggest that the gene was active inside the tumor and the gene was actively replicating or turned on, whereas lower levels suggest the gene was turned off. We have a genetic database of juvenile melanoma patients whose long-term outcome is known. Our sample is compared to this genetic database, and then the patient is classified as class 1 or class 2. Class 1 is further subclassified as 1A and 1B, with 1A with the lowest risk, 1B with intermediate, and class 2 having the highest risk. I just spoke about those 15 genes which help in doing this gene expression profile. So some of the genes are GNAQ, GNA11, which are associated with, which are touted as the initiating event for melanoma development, monosomy 3 and trisomy 8, which are associated with increased mortality, and BAF1 mutation, which confers the metastatic potential to the tumor. This BAF1 has also been attributed to familial cases of juvenile melanomas and other malignancies. There are ongoing trials with immunotherapy drugs which show promising potential. The gravest consequence of melanoma, like any cancer, is systemic metastasis. Unlike skin melanomas, juvenile melanoma spreads hematogenously, and most common affected site is liver. It can also involve lungs or bone. Hence, whenever we irradiate a patient, we do post-treatment screening in form of ultrasound, liver function test, and chest X-ray to the least. If possible, a CT scan, annual CT scan or MRI abdomen. The survival in metastatic cases is not that great. It's nearly about 50% in 5 years. The treatment options available are radiation ablation of metastatic deposits and palliative treatment. Immunotherapy trials with multiple drugs, to name a few, sunitinib, crizotinib, are currently being done with modest results. Let's move on. Let's first summarize our choroidal melanoma. So we saw that the ophthalmologic findings, the important ones are subretinal fluid, orange pigments, thickness more than 2 millimeters. They're usually slow-growing tumors. Fluorescein angiography may sometimes show double circulation. Autofluorescence shows hyper-autofluorescence orange pigments. Ultrasound helps us know the tumor dimensions. It can have mushroom shape, moderate to low internal reflectivity, and sometimes can also demonstrate, if present, an extrascleral extension. OCT is for subtle subretinal fluid or intraretinal fluid, and autofluorescence, like we discussed, for orange pigment lipofuscin. MRI can also be sometimes employed to look for extrascleral tumor extension. If we talk about iris melanoma, they have relatively a better prognosis and are detected earlier than choroidal melanomas. They can be circumscribed or diffuse. As you can see in the images, the above one is circumscribed and the lower one is scary enough diffuse. It most commonly involves the inferior iris. It is very important to look for neovascularization of iris and ectropia and uvea in these cases. They're usually along the pupillary margin. As you can see in the fundus fluorescein angiography, the tumor vessels are leaky, which can be appreciated as the tumor leak around the inferior border of the tumor. These leaky blood vessels can also give off blood in the anterior chamber, which can result in microhyphema. In all these cases, gonioscopy is a must. We have to look for tumor deposits, neovascularization of the angle, or pigment dispersion in all 360 degrees. If available, an ultrasound biomicroscopy should also be done to look for ciliary body involvement. The management can be done with plaque brachytherapy and excision. In cases of diffuse iris melanomas, enucleations can also be applied. Recently, we described a new technique of total anterior segment plaque brachytherapy for diffuse iris melanomas. Here, a large 20 millimeter plaque was placed over an amniotic membrane graft covered cornea to irradiate the entire anterior segment. As you can see in the first image, these are the marks for placing with the plaque, which is well 3 millimeters beyond the limbus. This technique gives excellent local control with no corneal side effects. The patients do develop cataract, but that can be easily managed. As you can see in the picture on the right, the cornea is pretty clear. Usually, these are 6 years follow. As you can see, these black spots in the periphery, these are actually vitrectomy holes. The multifocal biopsy was done using 27 gauge vitrector to confirm the multifocality of the tumor. Next, we have the ciliary body tumors, ciliary body melanoma. Due to its unique location, it may remain undetected for a long time and hence can acquire a large dimension before diagnosis. As you can see in the image below, the tumor is so large it can be seen with the dilated pupil. Due to proximity to the vortex vein, there is a higher risk of metastasis in these cases. Prominent episcleral vessels can often be seen in the quadrant of the tumor. They are called as sentinel vessels. These tumors can also be managed with enucleation or plaque brachytherapy. Sometimes they can involve a 360-degree angle, and that is called as ring melanoma. So this is more or less about uveal melanoma. Anybody has any questions or doubts? Or can we proceed?
Sir, what is the prognosis or 5-year survival rate of the uveal melanomas?
Okay, that's a very good question. Prognosis depends primarily on age, the tumor size, and like we discussed, the genetic profile. That gives us the risk. What is the risk of the patient developing metastasis? With so many evidence-based studies which are going on right now, we have a lot of calculators which are available online where we can feed in all the clinical data and we can get the customized prognosis for that specific patient. But on an average, if we look at the AJCC classification, the T1 stage, which is the smallest size, has about 10% risk of metastasis over a 5-year duration, whereas T4 has nearly 90% risk of metastasis over 5 years. So it depends on the tumor size. Like for postgraduate level, I think this is what is most relevant for you guys.
If I may add here, see, most of the genetic testing is not done in most of the Asian countries, right? And we see a lot less melanoma compared to the Western population. If you talk about both Europe and US, we see 1/20th of what a given center sees in the US or Europe. So first of all, most cases presenting to India, we see very, very large tumors. Secondly, we don't do genetic testing. So what I do in my clinic is there's a very nice paper by Carol Shields in JAMA Ophthalmology 2009, where she talks about millimeter by millimeter increase in the size of tumor. So every millimeter change in the height, she prognosticates. Like if it's a 2 millimeter melanoma, that has a 12% chance of metastasis after 5 years. Compared to a 10 millimeter melanoma, the risk increases by almost 40%. So it's a very, very nice table given in that this thing which I put up in my clinic, and that's what I tell the patient that this is. And again, location in terms of ciliary body melanomas are known to metastatize faster than choroidal melanoma. So for Indian perspective, I think we rely more on clinical testing than genetic testing. But otherwise, brilliantly covered, Ankit. Melanoma, you touched upon every single aspect of it.
Thank you, Dr. Vikas. I hope that clears it up. Shall I proceed?
The survival rate, something about survival rate or life expectancy?
Once the metastasis is discovered?
Yes, sir.
So we don't have a direct treatment for metastatic lesions right now. Like I mentioned, we do radiation ablation of the liver deposits if it's there, and we give palliative treatment. There are some experimental immunotherapy treatments which are available in the Western countries right now, but none of it has been published with great results so far. So it's approximately 50% over 5 years. And it's very variable. It depends on the patient's immune status. Some of the patients I have seen with Dr. Navar and Dr. Finger who have had metastasis and have lived beyond 10, 12 years, and some pass away within 6 months of discovering metastasis. So it's very variable and patient dependent, but on an average, 50% over 5 years.
Okay, sir. Thank you, sir.
All right. Let's proceed to the next topic. That's choroidal hemangioma. Choroidal hemangiomas are benign vascular tumors. They can be circumscribed or diffuse. They're usually red or orange in color. The circumscribed ones usually arise in the 4th decade. They can be associated with Sturge-Weber syndrome, which has port wine stain on the skin, ocular, circumscribed, or diffuse hemangiomas, and leptomeningeal angiomatosis. They are commonly seen around the posterior pole or optic nerve. They lack feeder vessel and intrinsic vessels. That's how you differentiate it from a retinal capillary hemangioma. Clinically. And they can grow in size and can have secondary exudative detachments, which is an indication for treatment. So if we look at the other imaging features of these lesions, so as you can see on the OCT, there is a dome-shaped lesion with the choroidal lesion with subretinal fluid. And here the fluid involves macula, which has resulted in vision loss. An important point for postgraduate student in these cases is that these patients have a hyperopic refractive shift. So it is very, very important to do refraction for these patients. This can help us assess the effect of treatment also. Below it is the fundus fluorescein angiography. The early image shows coarse vessels. These vessels light up in the choroidal phase, and hence it is very important to capture this image in the early few seconds as you have given the injection. As you can see in the diffuse phase, there is extensive haziness, and these vessels cannot be appreciated. It is also important to note that unlike choroidal melanoma, there are no microaneurysms here. So that's how, in case it is very rare to find this confusion, but in case if there's a lesion where you cannot differentiate between melanoma and hemangioma, fluorescein angiography is a very helpful tool. When we talk about the ultrasound, it again shows a dome-shaped lesion with moderate to high internal reflectivity. It can also have an associated retinal detachment. Now, when we talk about the treatment of these lesions, they can be if the patient is symptomatic, we suggest treatment for that. And they can be treated with photodynamic therapy, where a light-sensitive dye is injected and then it is activated by laser, or low-dose radiation in form of plaque or EBRT. The dose here is very low. For EBRT, we keep it around 16 to 25 gray, which is very low in comparison to melanoma. For melanoma, the plaque dose, the apical dose is planned for 85 to 100 gray, which is like 4 or 5 times the radiation that we're giving to this lesion. That's it about choroidal hemangioma in brief. Next, we talk about metastasis. So metastases are usually light in color, but they can be orange, pink, in cases of renal cancer metastasis, or papillary carcinoma thyroid metastasis, or it could be black in metastatic melanoma. But these are usually poorly demarcated. They can have RP spicules, and almost 1/4 of them can be bilateral or multifocal. They're usually around the posterior pole. Unlike choroidal melanoma, you can notice here that there is no gross orange pigmentation seen. Also to note that these lesions grow really fast. So in a duration of 6 weeks, they can almost increase in size by 50%, which is quite significant. Here in the clinical picture, we can appreciate the pigment deposits over the tumor. Look at the inferior surface and at the temporal surface. These are actually RP clumps. So when I look at the OCT scan through it, you can appreciate the undulating choroidal surface, also called as lumpy, bumpy appearance. So this is very characteristic of metastasis, also seen in lymphomas or leukemic deposits in the choroid. There is also some fluid pocket because of fluid secretion. The next image is of the autofluorescence. If you try and correlate with the clinical picture, the hyperautofluorescent spots correspond with the RP deposits. And the surrounding area is hypoautofluorescence. That's the hypoautofluorescence is because of RP atrophy. And the RP deposits are full of lipofuscin skin, and hence they are all hyperautofluorescent. This is another example of choroidal mets. Here we can see the fundus fluorescein angiography. And to note here, you can see that diffuse microaneurysms can be seen in the late phase, which is much more in comparison to melanomas. Like these findings become very obvious once you see a lot of these pictures. But more important for you guys is in the OCT, you can again see the multilobulated or the lumpy, bumpy appearance, which is very characteristic of a metastatic deposit. Remember that PET-CT scan is essential in these cases because we have to identify the primary, and management of the primary can often lead to resolution of these metastatic deposits. In case if the metastatic deposit persists despite the primary resolves, we can always irradiate with the help of EBRT or plaque. Next, we have choroidal osteoma. These are benign tumors, commonly seen in young females, yellow to white in color. A very important feature, these have scalloped edges. Like this is a spotter. You see the image and you know there is nothing else that could be the diagnosis. They can develop secondary CNV or serous detachments, and they don't have any gross orange pigmentations. Something to note here is that sometimes they can be associated with metabolic disorders of calcium, like hyperparathyroidism, or you guys must have read it in medicine, Bartter syndrome, Gitelman syndrome. Such cases have a bilateral presentation, and those osteomas have a tendency to grow because there is an underlying systemic abnormality which is not corrected. If we talk about the ultrasound, because they have calcium deposits in it, there is a very high hyperreflectivity with orbital shadowing, which is just of calcium. And if you look at the OCT, there is characteristic jagged appearance, as you can see pointed by the arrow, and there are internal lacunae present within the lesion. FFA shows poor early filling, and because it's almost like a scar tissue, there is intense late staining. If there is choroidal neovascularization present, that can also be highlighted by fundus fluorescein angiography. The treatment is primarily for its sequelae, that is, if there is serous detachment, if there is visual disturbance, or if there is CNV in form of laser or anti-VEGF as appropriate. If there is a systemic abnormality present, and if it is detected, then correcting it halts the progression of the lesion, and sometimes it can also start reverting. Some people have described lasering the lesion, but it results in extensive calcium release and can result in retinal atrophy overlying the osteoma. This is regarding the benign choroidal lesions. Do you guys have any doubts regarding the 3 topics that we've discussed? Dr. Khetan, would you like to add something?
So very nicely covered, Ankit. See, the other things that I would just like to add is metastatic disease, like Ankit talked about. Usually you have, even with a unifocal lesion in an eye, you can have massive exudative retinal detachment. So when the exudative detachment is beyond the size of the lesion, one must always think of metastasis as the first diagnosis. So a non-yellow lesion, I mean a amelanotic lesion with massive exudative detachment in Indian subcontinent, first thing you should consider is metastasis, second is tuberculosis, subretinal abscess. Only then comes melanoma in the schema of differentials. And in the picture that Ankit showed, there was another lesion in that same eye where he was talking. So it was a multifocal. So just go back to the picture. The previous one. Yeah. So you can actually see another lesion just above the disc. So it is very, very important to pick up these small lesions. All right. So the moment you see multifocal disease, a yellow lesion, subretinal, there are only 2 things that you can think of: choroidal mets and lymphoma. All right. Regarding osteoma, like he said, the only thing that we treat is if there is a choroidal neovascular membrane, and we can do anti-VEGF treatment. But there are people now who are actually treating the entire osteoma with PDT, because if it progresses, and sometimes deossification gives rise to large lacunae, and that causes a drop in vision. So there are groups that are proponents of treating the entire osteoma. Most often we don't treat, we just watch them, and we treat only the secondary complications of osteoma.
All right. Thank you guys for your patient listening, and thank you, Dr. Sinha and Dr. Khetan, for this opportunity. If anybody has any doubts, we still have some time remaining.
Question that Dr. Abhishek has put, differentiating points between nevi and malignant melanoma, and I think Ankit had covered that very well. He talked about most, which was the mnemonic that Dr. Finger has given. So I think
go back to that slide.
Yeah.
Like as PG students, I think if you guys carry this message with you, it will help you along later, even if you do not take up ocular oncology as a subspecialty.
Yeah.
So any pigmented lesion, if you are confused if it's a nevis or a melanoma, remember most: M for melanoma, O for orange pigmentation, best seen with autofluorescence, S for subretinal fluid. The subtle one can be detected best with OCT, and tumor thickness more than 2 millimeters on an ultrasound. If all these 3 are present, consider that there is a very high suspicion it's malignant melanoma. The other suspicious features are proximity to optic nerve, if the patient is symptomatic, and if there is absence of drusen, absence of hyperpigmented halo around the lesion. And once you have all these features, then you know it's a malignant melanoma.
So just to add to that, all these 7 features have been another terminology that the Shields have given is TFSOM. They call it as to find small ocular melanoma. And later they've added UHHD to that, called as using helpful hints daily. This is something that you can easily Google and you can find, but the features are the same, these 7 features. And in the end, they've also included ultrasound finding for a small melanoma. But features are the same. So whichever mnemonic you remember, these are the features that you've got to look for.
Anybody has a question, you can directly unmute and ask also.
Ankit, any relationship with Pan Singh Tomar?
Funny question, but he is a distant uncle.
Okay.
Like I hail from Gwalior and he belongs to that region.
Yeah, so for those of you who don't know, Pan Singh Tomar was a very famous athlete and then eventually had to become dacoit in the Chambal Valley because did not get support from the Indian government and anything. So, and there's a movie made on him. Irfan Khan was the actor in the movie. So this is non-academic, but just because Ankit's name resembles, I thought, to make the mood light.
Yeah, it's a good alternative option for me. If nothing works out, then dacoit it is.
You do very well. Very nice class, Ankit. Very, very well. So,
Thanks, sir.
Yeah, precise. And if for the postgraduates, you see the material in his slides was very little. He was looking at the slides, showing you the pictures and talking. So another thing is learning how to make PowerPoint presentations. You should avoid filling your slides with material. So if you know your stuff, keep as little as possible on the slides. Put more pictures and talk about and explain the pictures in detail. So well done, Ankit.
Thank you, sir.
Thank you so much, Dr. Ankit, for the wonderful presentation. These presentations are going to go through YouTube into the different medical colleges pan-India. So it's going to be very helpful where such advanced teaching is not possible. Your presentation is going to be very helpful for the postgraduates over there. I get emails every day from all over the country, from all the medical colleges, how these presentations are helping them. And your presentation is going to be one of the most helpful to them. Thank you so much. And thank you, Dr. Vikas, for wonderful moderation. And we are looking forward to seeing you again tomorrow. Tomorrow we have with us the man, Dr. Santosh Vanawar, and he will be speaking on ocular surface tumors, and that is going to be very interesting. I would like to thank Manish ji from Intas and Chandrasekhar ji from Intas Pharmaceuticals for bringing this all together. Thank you very much. And Afifa Azam has written very nice class, sir. Thank you so much. I'm sure many postgraduates will be very grateful to you because we are compiling this into a whole library for postgraduates. So this is going to be a part of it, and all of them are going to be very obliged to you. Thank you so much once again, Dr. Ankit, and we wish you good luck. And we want to see you rising higher and higher. And in a few years, we'll see you as one of the superstars of oncology in India. Good luck, and thank you so much.
Sir.
Thank you so much once again.
Thank you, Ankit. Thank you, Satyajit.
Thank you. Bye-bye.